Thanks for the invitation and the organization to HPB Society in Turkey, and especially Dr. Professor Gürkan Tellioğlu for his great efforts in organizing this meeting. We envisioned, I don't know if the Zoom is hearing us okay. If not, then we'll do something about that. We envisioned this to be a little bit informal in the sense that if there are any questions, if you have any comments, please raise your hand, and maybe Zoom, they can also inform us and we can just stop and have further discussions. So actually, I organized this talk. So the second part of the talk, I integrated to the rest of the presentation, some of the challenging issues. And I tried to approach to the differential diagnosis in pancreas pathology in a more algorithmic way. The first part will be more radiology and gross-based classification and how we use really radiologic appearance of tumors in classification of pancreatic neoplasia. I think this will introduce us some concepts and also help in our daily practice, hopefully. We have a dichotomy in pancreatic pathology. For tumors, there is the dichotomy of the solid versus cystic lesions. When we have a solid lesion, the vast majority of those prove to be pancreatic adenocarcinomas or some other malignant neoplasms. When there's a cystic lesion, we are a little bit more happy for the patient because there's hope that this could be more benign or low-grade neoplasm. So that's where our algorithmic approach starts from the get-go. And then the solid tumors also we evaluate in two broad categories. The first one is the more scar-like, serous, ill-defined lesions that are difficult to recognize both on gross examination and as well as radiologic examination. And the second group are the fleshy demarcated ones. They are fleshy by gross examination. They typically appear as homogeneous lesions in radiologic examination. And the differential diagnosis for these are significantly different. Their microscopic correspondence for the scar-like or serous lesions, we often have a lot of desmoplastic stroma or fibrotic participation that gives that more scar-like appearance. Whereas for the second group, there's a lot of cellularity, and that cellularity leads to more homogeneous lymphoma-like appearance of the tumor. When we come to cystic lesions, we also have dichotomy, although we don't use this as much anymore because the group that's called microcystic, meaning there are numerous tiny little cysts, hundreds, and forming this well-demarcated lesion, this is very characteristic of serous cystadenoma. So there's only one entity in this arm of this differential diagnosis, whereas the megacystic ones, meaning large cysts with multiple loculi, each locule is relatively large, then we have a wide spectrum of differential diagnosis for those. So this is the broad differential diagnostic four groups that we deal with, and then that's how our differential diagnosis starts. For the serous ill-defined lesions, for this group, the main differential is between pancreatic ductal adenocarcinoma and chronic pancreatitis. So they're vastly different. Most of them will prove to be pancreatic ductal adenocarcinoma. By the way, during this presentation, I will call PDAC referring to pancreatic ductal adenocarcinoma, the main tumor of the pancreas. For this group, we have and for pancreatic ductal adenocarcinomas, the most important issue, this slide is probably the most, one of the most illustrative examples, is the presence of, again, abundant stroma, collagen, desmoplastic stroma. So this picture here probably summarizes most of the problems in pancreatic pathology. If you take a needle and insert to this tumor, you can imagine we'll just see one gland that is abnormal, and the rest of it will be all fibrosis. Embryologist calls me down to endoscopy unit and he says, look, we are right in the middle of the tumor and you're telling me there is nothing here. I am telling you there is nothing because, unfortunately, often there's a lot of fibrous stroma with minimal cells or no cells in pancreatic adenocarcinomas. Same is true also for frozen sections. If you take a frozen section of this area, we'll see just one gland, and it may be atypical, and we may give you the diagnosis. There's an atypical, maybe carcinoma, I'm not sure. And the next day, when we look at the whole section, the permanence, then we realize actually that gland was also part of the adenocarcinoma process. So suddenly we realize it was an adenocarcinoma. For the fleshy, demarcated, the homogeneous tumors, the differential diagnoses are essentially on all non-ductal neoplasia of the pancreas. And we'll come back to what we mean by non-ductal, but just to list them briefly here, neuroendocrines, acinar, pseudo-papillary pancreatoblastoma, and always in the differential, of course, are secondary tumors and metastatic lesions to the pancreas. For megacystic lesions, as you know, mucinous ones, IPMNs, MCNs, IOPNs will go through these abbreviations to explain them better. And there are a whole host of other cystic lesions that occur in this organ that present as these megacystic and multilocular cystic lesions. And as I mentioned earlier, this pattern is actually very specific in the sense that when I see this, we don't even have to take microscopic examination. It's that specific for serous cystadenoma. Just one section will do the trick, and they're often large tumors. In contrast, for these kinds of lesions, as we'll come back to, we need to do a lot of sampling and examination to rule out cancerous transformation. Now, this algorithm works really well. It's quite consistent. However, as in anything else, there are also exceptions. There are PDACs, although most of them are solid, about 3 to 5% can present as partially cystic masses. Similarly, neuroendocrine tumors, about 5 to 10% of them present as cystic lesions. Although SPNs are called solid pseudopapillary tumors, actually a significant proportion of them have cystic degeneration such that in the past we used to call them solid and cystic epithelial neoplasm, papillary cystic epithelium. So the word cystic was in the name of this entity in the past. And yes, we discussed microcystic adenomas being very specific, that microcystic pattern being very specific for serous cystadenoma, but there are solid versions of this entity, typically misdiagnosed clinically as neuroendocrine, because as you can imagine, homogeneous is not showing the same microcystic appearance that's characteristic of the entity. So these exceptions, of course, need to be kept in mind, because when this happens, of course, it's 100%, right? That's one patient, and that's it. So it's important to keep this in our differential. So when we come to the frequency, and even in great textbooks on the topic, you'll find numbers that vary greatly. But this, I think, summarizes the current reality in the best manner. The majority of the pancreatic pathologic lesions are actually cysts. But that's because cysts are very common in the pancreas, as we'll hear in the afternoon from radiology perspective. If you look hard enough, you find cysts larger than 2-3 millimeters in all elder population, almost half of the population. So they are much more common. But when you come to the resection specimens, what we are exposed to as surgeons and pathologists, of course, the indications are different and the reasons to operate are different. So about 60% of the resections are for pancreatic ductal adenocarcinomas or their mimickers, and about 30% are cystic lesions that are more pre-malignant, and about 10% of the resections occur for, of course, this changes from institution to institution, but these are the ballpark numbers that can be kept in mind. So these 4 groups that I illustrated to you, we mentioned some of the respective findings, but I would like to go over the challenges that each group presents, challenges for both pathologists and during daily practice. The serous ill-defined ones, again, the differential being PDAC versus chronic pancreatitis. As you can imagine, when a biopsy is performed, it's typically not very cellular because the collagen doesn't come into the biopsy. It yields some glands, typically. The problem is those glands can be atypical, but may not be definitive as a cancer, or we struggle whether it's reactive atypia versus true adenocarcinoma. When we come to the homogeneous demarcated group, the differential is very different, as I mentioned, non-ductal ones. These yield fairly cellular specimens because, as you can imagine, the tumor is very cellular. It doesn't have much stroma. So if you can really, if they're not small, if they're big enough, often these days, not in the past, but these days, fine needle aspiration can extract fair amount of cells. And the cells are often monotonous because all these entities are characterized by more monotonous cellularity. So we can come to the conclusion that we are dealing with this group in most examples. The problem is which one of this group becomes an issue. There was a discussion a few weeks ago in our bi-weekly meetings whether this group is really diagnosable by FNA. It really is. I mean, FNA can be extremely effective in dealing with this group. Again, with the caveat that we may not be able to be specific for neuroendocrine versus SNR versus others at times. So the challenges this solid group present, as I mentioned, especially the abundance of desmoplastic stroma, this becomes a more significant problem for bile duct lesions. We see collagen and we see few very atypical cells. One thing I can tell for the pathologists in the audience, if you see a very hyperchromatic boxcar nuclei emits collagen, that's most likely adenocarcinoma. In ulcerated regions, we ignore this kind of atypia, but in a posticellular fibrotic stroma, this is often indicative of adenocarcinoma. And target units can be really widely scattered. This is a common bile duct frozen section edge. And you see there are only few glands, and then, of course, it becomes challenging to make the diagnosis. And much more important for us pathologists is the adenocarcinomas can be deceptively benign appearing. They look so mature. Actually, I like showing this picture in pathology courses because this really looks perfectly normal and benign looking gland, but it's actually from a metastasis in a lymph node. And it's really hard pressing to call this adenocarcinoma due to its maturity, but there are some subtle findings we make use of to recognize it as adenocarcinoma. Bile duct brushings, will come back and we'll present you a case later on. Bile duct brushings are really, in terms of small biopsies and FNAs, are the hardest because you know, pancreas is hard to induce ulceration in the pancreas or just too much reaction or inflammation. But common bile duct gets inflamed even with standing and prior biopsy, and that inflammation leads to atypia, and then it becomes very difficult to distinguish from adenocarcinoma. Here is one example. Only few cells to make a determination from, and most pathologists, we did a consensus study at some point, most pathologists did not want to call this adenocarcinoma. Some of us did, and it was indeed adenocarcinoma with a lot of neutrophils. It was not reactive atypia. But again, to illustrate to you the fact that it can be quite subjective and difficult. We mentioned that solid serous lesions, the vast majority of them, when you have this scar-like configuration, they will prove to be pancreatic ductal adenocarcinomas. But important to keep in mind, not all of them are that. What I call pseudotumoral pancreatitis, meaning benign chronic pancreatitis or benign conditions that can closely mimic adenocarcinoma due to mass formation, ill-defined lesion, occurs and accounts for about 4 to 13% of pancreatitis in any institution you go. That's not talked about much, of course, but in any institution you go, this figure goes from, nowadays it's less, but it used to be around 5%. It's probably down to about 2% these days with improved MRI and other technology. Nevertheless, 1 in 50 patients, you will think you're operating on an adenocarcinoma, but it will prove to be this pseudotumoral pancreatitis. And the two entities that really need to be kept in mind, one of them is autoimmune pancreatitis. Let's start with that. Autoimmune pancreatitis, you see how the pancreas is entirely abnormal and replaced by fibrosing inflammation here. Actually, this is quite a nice example because it has that posticellular fibrous band in the periphery that creates a halo in radiologic examination, which allows the diagnosis of this entity. By the way, why is that halo forming? Or maybe the question should be, why isn't the halo form in PDACs? Because PDACs don't stop where they go, right? PDACs are very infiltrative, and we'll come back to that point. They do not stop at some point to create this halo-like reaction around them. So this is a good clue to the diagnosis of autoimmune pancreatitis. When you examine the lesion itself, you often find significant duct-centric lymphoplasmatic inflammation, what we call periphlebitis, meaning selective inflammation and obstruction of some of the veins, you see a healthy vascular structure next to it. And also important are abundant IgG4 positive plasma cells. So this, what we used to call autoimmune pancreatitis, the current name for it is actually IgG4 related sclerosing disease. It was originally described in pancreas. It's still called autoimmune pancreatitis type 1, but is in the spectrum of IgG4 related sclerosing disease. Now, one comment I would like to make of this entity, when this was first recognized, the field did not realize that it can really look like cancer. And a lot of the autoimmune pancreatitis cases got operated as cancer and could be perhaps avoided. Now I think everybody learned about this, and now we are in the other end of the pendulum. We are calling things a little bit more readily as IgG4. We see a mass. Oh, you know, there's inflammation, biopsy shows some plasma cells. Oh, maybe this is autoimmune pancreatitis. I think we are harming the patients by doing that too. So real careful workup, close and frequent follow-up is needed before jumping into the conclusion of autoimmune pancreatitis. I don't want to get into the details, but IgG4 plasma cells are actually everywhere. So don't do duodenal biopsies or ampullary biopsies. There was literature on this at some point. Why don't we do ampullary biopsies? If we see IgG4 plasma cells, we can make the diagnosis. Absolutely not. Please don't even think about it. There's no diagnostic test by mucosal biopsy to make this diagnosis. You have to have the constellation of all the radiology, IgG4 plasma levels, what the patient has, and the follow-up, and etc. But mucosal biopsies, please don't do them. IgG4 plasma cells are everywhere. Pilonidal sinus, for instance, most surgeons know, have the highest number of IgG4 plasma cells than anything else. And they are pilonidal sinus. Okay, so we need to be careful not overdiagnosing this entity. Going back to the other entity, actually, depending on the population, like where I worked in the US, this was very common, probably due to alcohol consumption, paraduodenal or groove pancreatitis. They really present like periampullary cancers, often localized on the accessory ampullary component of the duodenal wall. So endoscopically checking the accessory ampullary region and focusing on some of the salient features may allow the diagnosis of this, but you see what a mass lesion they can form. This more yellow spots here are remnant pancreatic elements. All the white and hemorrhagic things are actually the pseudotumor mimicking the cancer. When we come to the, am I going too fast? I tend to go really fast. Is it okay? Followable? Yeah. Cellular monotonous group, the ones that again form more demarcated, sometimes even encapsulated lesions. For this group, again, the differential is non-ductal neoplasia. We often on cytology can tell these are non-ductal, or we put ourselves into this differential diagnosis. However, there may be challenges in distinguishing between these. We have learned, we have seen so many of these. Now I feel quite comfortable, and our team, we make the distinction and diagnosis probably more than 98, 99% of the time now. But in the learning curve, this can be really difficult for pathologists who are not as familiar or seeing these things as commonly. So depending on where you work, you need to understand how difficult this can be and be patient about that. Non-ductal tumors, I put here the most characteristic examples just for you to appreciate what they're about. These neuroendocrine tumors are characterized by isletic or nest-like configuration with prominent capillarization that gets translated to radiology. When they are well differentiated, the acinar cell carcinomas do really resemble acinar cells with the acinar granules in them, truly zymogen granules. Unfortunately, most acinar carcinomas do not bother to do that. They are poorly differentiated. Solid pseudopapular neoplasms are peculiar in the sense that they have beta-catenin and E-cadherin alterations that lead to this selective discohesiveness of the cells away from the vascularity, and that's why they have a pseudopapillary formation, as you see here, almost rosette-like configuration. And pancreatoblastomas, as in any other blastic tumor, have multiple cell lineages. Pancreatoblastomas, by definition have, not by definition, almost always have acinar differentiation, very frequently have neuroendocrine differentiation, and occasionally even ductal elements in them as seen in this example. So they are blastic in the sense that they can go into multiple lineages. The problem is often these are poorly differentiated and do not bother to do the mature representations of their cell lineage. So pseudopapillary neoplasm recognized by the beta-catenin expression, acinar carcinomas by trypsin expression. Trypsin is one of the enzymes, they highlight this. This is one diagnosis that makes me very uncomfortable in pancreas pathology, because when it is really poorly differentiated, we have to rely on the immunohistochemistry, on the trypsin. And if your trypsin is not working, you are doomed, because it becomes very difficult to make that diagnosis. Immunohistochemistry is an extremely helpful tool. It's never the sole determinant. We mostly base our diagnosis on morphology, but there are cases in acinar cell carcinoma that we really need to help from trypsin, and if your trypsin is not working that day, then that becomes a big problem. Pancreatoblastomas are actually acinar carcinomas or neuroendocrine neoplasms that have distinctive, these moral formations that are beta-catenin positive. I don't want to go into the detail. One thing I can tell you as clinicians and surgeons, pancreatoblastoma is severely underdiagnosed in the community by pathologists due to lack of recognition. Sometimes they present as retroperitoneal mass, and unless you think about it and do your proper stains, it gets diagnosed as all kinds of sarcomas, even to Ewing sarcomas and other things, unfortunately. So coming to the cell lineage-based classification of pancreatic neoplasia, now pancreas is composed of essentially 5 elements, the most common one or most abundant one being the acinar cells. Islets are scattered as independent organs almost within the pancreas. We have the ducts and we have the supportive tissue. Now ducts, although they are not the most abundant and although they are the simplest, those are the ones that gives us the biggest trouble. Presumably because they're exposed to the outside world. Presumably because they are more proliferative and more primitive. They are the ones that lead to cancers most often. So most of our neoplasia in the pancreas are of ductal type or ductal lineage. So by the way, we say ductal origin. You know, my concept is, I don't know when it originated. I wasn't there. I couldn't prove it. So we prefer to call it ductal lineage or ductal differentiation. So we see what it is doing rather than where it is coming from. So ductal lineage is characterized often by mucin production. Now, mucin can be intracytoplasmic, and in most cases it is. And mucin can be stromal abundant, like mucinous colon cancers, in which case we call it colloid carcinoma, and it has a much better prognosis. And mucin can be luminal, secreted to the lumen of the ducts, as in IPMNs, which can then be even extruded from the ampulla of water, creating this diagnostic mucin oozing from the papilla of water appearance. So there's a spectrum of mucin formation. Of course, the more it is, generally, the more it's good in the pancreas, but it doesn't always work that way. And along with the mucin being the hallmark or main lineage specific finding, KRAS mutation is also very common in any ductal neoplasia. Even when ducts are injured and they show metaplastic changes, KRAS mutation comes in. With that, I would like to emphasize to you, presence of KRAS mutation doesn't mean cancer. Unfortunately, there's literature kind of indicating that, but KRAS mutation can occur in very early neoplastic transformation when things are low-grade dysplastic but not yet cancerous. And along with the mucin formation, MUX, CEA, and CA19, which are mucin-related oncoproteins, are often expressed in the cells and often secreted both to the blood, so we can detect some of these things in the serum and also in the cells as well, and also in the cyst fluids. I mentioned earlier, invasive ductal adenocarcinoma, what we call PDAC, pancreatic ductal adenocarcinoma, is in the spectrum of pancreatobiliary type adenocarcinomas, which are characterized by tubule formation, these glandular structures with some mucin in them, if you do mucin stains, desmoplastic stroma leading to the scirrhous appearance. Now, one thing about PDAC, And if we can understand why and resolve this, we'll be very successful in treating this tumor. It has very high propensity to infiltrate things and very comfortably spread through them. Perineural invasion, see 90% we say, but probably if you look carefully enough, if you do step sections, maybe even higher than that. Vascular invasion is very common. The striking thing is, even when they infiltrate the nerves and vessels, they still line them. I jokingly say they almost want to be nice. They're like psychotic cells that are trying to do something mature, something nice. But the problem is also with this, they can spread far away from the original tumor. And that is the biggest problem for surgeons. By the way, this ability to line things and just spread through surfaces also manifested in when they metastasize to other organs. A metastatic PDAC in ovary, please keep this in mind. I'm sure during your practice this will happen. Metastatic PDAC in ovaries are often misdiagnosed as primary mucinous cyst adenoma, not even borderline, adenoma, because they are so mature, they form these nice cysts, and we have a large collection of these cases, and there are many studies on this, and they present as a, and actually that's more common for them to present as cyst when they metastasize to ovary than as solid tumor. Some fascinating phenomena. And they do the same thing when they metastasize to lung. They line the alveolar spaces leading to this bronchial alveolar carcinoma pattern. So let's say you resected a PDAC and the patient has lung. By the way, lung metastasizing PDACs often behave well. I don't know why, but solitary lung metastasis cases, and we've seen many of these examples, it must be some propensity biologic phenomenon that if there's a solitary lung metastasis, that's actually often good news for the patient. There was a patient, everybody knows, in American hospital, I think Oranoja had operated, alive 8 years later, unfortunately died later on. So this is, the reason I'm telling you this is when you have a PDAC case and a lung had a solitary lesion, they resected it, and pathologist is calling it bronchial alveolar primary carcinoma, it may be good to tell them, look, you realize this patient has PDAC. Would you like to re-review your case? Because often it will prove to be a metastatic PDAC. Now, pancreatobiliary type adenocarcinomas also encompass as a group gallbladder, cholangios, extrahepatic, and a subset of ampullary carcinomas because they have very similar morphology, very similar spreading patterns, desmoplastic stroma, aggressive behavior that makes us kind of collect them under one heading, although increasingly we are seeing subtle molecular and other differences between these two. But currently, that umbrella category helps us because you send us a biopsy like this somewhere in the peritoneum. I cannot tell if this is from pancreas or bile duct or intrahepatic. You know, all I can say is this looks pancreatobiliary. It may be gastric because pancreatobiliary adenocarcinomas and gastric foregut adenocarcinomas have overlapping morphology. So that's why we collect them under this heading of PB adenocarcinoma. Here are examples. This is distal common bile duct cancer. This is a non-ampullary duodenal cancer that has pancreatobiliary features and ampullary ductals that are overlapping morphology, but they have the same aggression, similar immunophenotype, etc. Having said that, depending on where they are localized, of course, they have some subtle differences and behavioral differences. In our experience, ampullary ones do much better than the pancreatic ones. And this is, most of the literature also indicates that. But that may be, you know, spreading pattern, early detection, and other factors may be playing a role in this, obviously. Now, one thing that we all always have to emphasize is not all pancreatic adenocarcinomas are the pancreas cancer. So PDAC has become almost so common and is so important and is so critical that it is now common synonymous with pancreatic cancer. So, I mean, this question comes up, of course, with came up with the iPhone guy. What's his name? Yes, Steve Jobs. Steve Jobs, when he was diagnosed and 3 years later he was still alive, right? People were calling me and said, you say PDAC, in those days PDAC was killing within 1 to 2 years. He was alive after 3 years, and said, like, that's because he is rich, he can get good therapy and stuff. Actually, the reality is Steve Jobs, you know, he always thinks outside the box. He had a neuroendocrine tumor, but he thinks outside the box. He refused the treatment. He wanted to have herbal treatment. If he had gotten resection at that time, he could have been even cured. So the point here is not all things are called pancreas cancer are PDACs. In fact, in many institutions, we check the database, and when you go back and look at databases, surgical databases, often things that have been advertised as PDACs, especially if they are long-term survivors, prove to be from common bile duct ampulla, neuroendocrine tumors, IPMNs that were called malignant because they had in situ carcinoma, et cetera, et cetera. So it's important to keep not all pancreas cancers are PDAC. Now, malignant neoplasms of ductal origin, even there are important subgroups evolving, developing in this ductal, if you will, ductal cancers, ductal adenocarcinomas. One of them, of course, the most common is ordinary PDAC that I illustrated to you. There are some morphologic variants. This is the foamy gland I showed earlier. Some of them form very large ducts. Some of them form these cribriform vacuolated structures. Currently, we do not know the meaning of these variants, but increasingly these are proving to be different molecularly. So in time, these may be different targets for oncologists. Right now, they are just morphologic curiosities. We don't even report them, but we notate them for future studies. Now, when we come to this group, now this group is significant. These are PDAC-related tumors. They are almost like de-differentiated, higher-grade transforming metaplastic versions of PDACs. They are of ductal origin, ductal differentiation. They are often accompanied by ordinary PDAC. So you find the conventional tubular PDAC component somewhere, but they also have a distinct component that changes the biology of the tumor. For instance, adenosquamous carcinomas. Unfortunately, adenosquamous is defined in WHO as more than 30% having secondary component. But in our impression, even if there's focal squamous differentiation, it's probably already on its way to become a different tumor. Once you define it with 30%, these are relatively uncommon. 1 in 50 PDACs have adenosquamous. They tend to cluster together with the basal-like group. By the way, this is coming to pancreas from breast. In breast, you may know there is luminal A, luminal B, classical basal types that are treated very differently. We are going in that direction in the pancreas as well. The basal-like group is proving to be different molecularly and biologically and will probably require different treatment in time. And there are these bad actors like adenosquamous, but there are peculiar tumors that have also ductal lineage, also have conventional PDAC component, but if they are predominant, like colloid carcinomas, they actually behave quite well. Please keep in mind, these form large tumors, gelatinous, a little bit more demarcated than usual. These are intestinal lineage cancers in the pancreas. They have MAC2, CDX2, which are very good intestinal lineage markers, and we believe these need to be treated more like intestinal cancers, perhaps. Of course, there's no randomized study on this, but they're really, everything about them indicates they are intestinal type adenocarcinomas, and their 5-year survival is more than 60%. They often arise from IPMNs, so they become important in analysis of IPMN groups. A subset of PDACs that's becoming interesting and significant are those that don't show the classical sclerotic scurus pattern. We are illustrating the classical PDAC features here. Again, pseudotumor-like, scar-like appearance, ill-defined, tubule-forming desmoplastic stroma. Now, there are cancers in the pancreas that are of PDAC origin, but instead they form these demarcated tumors that have central necrosis and much more cellularity and pleomorphism. We call them centrally necrotic hyalinizing demarcated cancers. Actually, they are metaplastic in their lineage, basal-like. They have the GATA6 loss. I don't want to bore you with some of the molecular details, but the important thing for you to keep in mind in your daily practice, if you see a nasty PDAC, but it is demarcated with central necrosis, you may be dealing with this group. I think this group will be treated differently by oncologists in the future as well. This one is a very peculiar entity illustrating the plasticity of cancers. Somehow this cancer is attracting a lot of osteoclasts, which is actually a bone cell. And somehow these bone cells are abundant in this tumor. Why they come there, we don't know. But once they are there, they must be doing something because these guys behave significantly better. Not all of them, but a subset of these behave significantly better than our ordinary PDACs, although they look undifferentiated and high grade. Again, these are also more demarcated cancers. Now, we come to probably a group that is more significant because there's subtle features that need to be appreciated in daily practice are what I call the tumoral intraneoplasms associated cancers or adenoma carcinoma sequence, meaning IPMN, MCN, ITPN, IOPN related. I know these abbreviations are very scary, but I'll try to clarify them for you. Let's start with the concept first. Tumoral intraepithelial neoplasm. What we mean by that? Dysplastic cells forming large masses, just like an adenoma in the colon. But unlike adenomas in the colon, they are growing in the ductal system typically, so they cause cysts. So cystic and intraductal neoplasia is this group. Again, adenoma carcinoma sequence. So the theory or the observation is whatever is leading these dysplastic cells to keep growing within the ductal system and form these large cystic papillary nodules are conferring a different biology. So they start to act different than our ordinary pannin-related PDAC pathway, our ordinary cancer pathway. And this also brings us to the cystic lesion and the classification of cystic lesions. Everything okay? Classification of the cystic lesions. This is not an official classification, but I think it's a good way to look at different lesions. It's through cyst, and there are degenerative cysts. Degenerative ones meaning pseudocysts and also solid tumors that have necrotic degenerative changes. Now, these are often malignant neoplasia with degenerative necrotic phenomenon. The true cyst mostly proved to be mucinous in nature, and we mentioned very common cysts in the pancreas. Most of them proved to be actually this mucinous group and IPMNs. We'll go into the details of the classification of these further, but the important thing to recognize is that these are pre-invasive, precancerous lesions. They may have cancer at the time of diagnosis, or they may develop into cancer in time. Now, everything okay? Anything I need to do? All right. Mucinous lesions used to be very confusing at some point. Now we classify them as based on ovarian stroma. Those with ovarian stroma are called mucinous cystic neoplasm, and if there is no ovarian stroma, then we go to the IPMN. This is the algorithm. To the IPMN, its mimickers or one of the related or their kindreds, cousins, as I call them, is what we are dealing with. Ovarian stroma is indeed ovarian stroma. So mucinous cystic neoplasms you see, they are defined by ovarian stroma. Without ovarian stroma, we do not call it mucinous cystic neoplasm anymore. All the literature is different. So when you see a paper, for instance, that says we analyze mucinous cystic neoplasms, and 80% of them are women, they're probably including IPMNs and other cysts, because if you define the entity by ovarian stroma, 98% are females. I've seen 3 examples that were in men that had convincing ovarian stroma, but that is unusual. And most of them are also in the body and tail, forming these demarcated multilocular cysts. They are obviously of ductal lineage, ductal origin, but they do not show overt communication with the ductal system. We presume they're arising from the really very small branch duct-like things, maybe duct chews, if you will, and with the ovarian stroma, and they form these isolated multilocular cysts. Here's a beautiful example of adenoma carcinoma sequence, low grade versus high grade. If you have only this, we'll call this a low grade lesion. We just follow the patients at home. If this is carcinoma in situ, by the way, WHO does not want us to use the term carcinoma in situ in GI tract and pancreas. I think it's not good. Asians do it, and I also use it parenthetically, high-grade dysplasia carcinoma in situ, because this is carcinoma in situ. These are cancer cells that have not yet invaded. They carry all the mutations and all the features of cancerous transformation. Some of them are really large. Even I can tell that this patient has hip dislocation by looking at this radiology here. Joking aside, they can be quite readily identifiable because of their large size. But large size may not mean that much. It's the more nodule where the cancer develops is what we need to focus on. Just like in IPMNs and MCN2, mural nodules, papillary elements, complexity actually reflects the cancerous transformation. By the way, earlier literature, MCN, the papilla formation was not emphasized. Just like IPMNs, they have papilla formation. And in fact, those that have papilla formation, which I presume will translate as mural nodules in radiology, although I have not confirmed that, papillary nodules are the ones that will develop cancer in most instances. So it's unusual for just multilocular cysts without complexity and nodules to become invasive in MCN. MCNs have invasive carcinoma in about 1 in 6 cases, typically larger examples. Just like in, actually, I really think Sendai-Fukuoka criteria can be used for MCNs. Extremely unusual for a MCN that's smaller than 4 centimeters to have invasive carcinoma. But the issue is, how long are you going to follow? The same old question, right? Okay, it's 3 centimeters. Are we going to wait for this 50-year-old lady? How long are you going to wait? So taking it out still, I think, is probably more justified, because they can progress if you give them time. Most of the invasive cancers that develop in MCNs are PDACs. So that's why, yet another reason, MCNs, yes, if they are non-invasive, perfect, send them home. But watching it, once they become invasive, just like branch duct IPMNs, once it's invasive, it's bad kind. So we don't see colloid carcinoma, for instance, in these guys. So invasion is really bad. In our experience, once it's invasive, 5-year survival drops to 20%. Yes, there's a study that says if they are very minimally invasive, they are cured. They have good prognosis, but minimally invasive, they are just less than 2-3 millimeters, and some of them look like maybe they are not really true invasion, but just invagination. So, but in our experience, even small invasion in MCN is not good news. Coming to the IPMNs, there's a preoperative algorithmic approach to IPMNs as branch duct versus main duct. Branch duct IPMNs often preserve the main duct, but often you also see a little bit of involvement, but minimal. It's at least not dilating, it's not dilating the main duct and showing this granularity. This is probably the answering duct, by the way. And the multilocular cystic transformation, with these are the papillary nodules. And again, sampling needs to catch these things, because that's where often cancerous transformation also take place. Main ducts typically are much more florid, papillary, and involving both main and branch ducts in a very complex fashion. And not surprisingly, of course, that leads to obstruction and chronic pancreatitis. Whereas in branch ducts, the rest of the pancreas could be pristine, very clean. As illustrated in this example, they are multilocular cysts. Now, for cytology and diagnostic purposes, these branch duct IPMNs, we can help you in a very limited fashion, because you do an aspiration, it doesn't yield cells. There won't be cells, and if there are, they won't be readable. Even the presence of mucin, sometimes we use in cytology. Oh, there is abundant mucin here. Maybe you're dealing with an IPMN. But our help to you in diagnosis of this is quite limited. Of course, chemical analysis and stuff can help a little bit, but in my opinion, most of it is high-quality radiology will be the most helpful in assessing these lesions. Don't get me wrong. Of course, you can do EUS, because if there is, sensitivity will be very low. But if we see convincing cancer, then you gotta really go in, because our purpose in IPMN is to catch it in situ carcinoma, high-grade dysplasia, before it becomes invasive, no? So that if we catch it in that stage, that's the best help to the patient. And probably the only way to say this is really in situ carcinoma is still cytology. So I don't know if I'm explaining it properly, but sensitivity is low, We may not be able to help you in most cases, but if you do FNA and we tell you, look, there is carcinomatous transformation here, then we are doing great help because that's the time to resect for sure immediately. Adenoma carcinoma sequence illustrated nicely here in this IPMN that is intestinal type. If I show this picture to pathologists, they will say this is villus adenoma of colon. It really looks like that. And here it's intramucosal adenocarcinoma or carcinomatous transformation. You see the complexity. You know, even those of you who are not doing pathology every day, I'm sure appreciate this carcinomatous transformation here. That's why these are adenoma carcinoma sequences that eventually lead to invasive carcinoma in substantial proportion of the cases if this is left alone. Just to go over, there are different types of these IPMNs and intraductal neoplasia that have different associations and different progression into cancer rates. The most problematic one are the gastric types. Most incidentalomas, you know, those little cysts that we find in pancreas, prove to be gastric IPMNs. Not all, but most. Now, and they're often small, as you know. And we use, this is Sendai-Fukuoka criteria is actually mostly for these guys. The problem is, invasion is, in long term, about 15% of these develop the invasive carcinoma. The problem is, when they infiltrate, it is the bad kind, it's PDAC. So it looks innocuous, it's often quiescent, it just stays there, but when it transforms into cancer, it's too late. And it can transform into cancer, you know, there are, I'm sure some of you are following that literature, the high-risk individual early cancer diagnosis, they follow families with IPMNs, they follow IPMN patients, and many, many examples, they did an MRI, they didn't see anything, 3 months later, patient comes with 2 centimeter PDAC. So that concept that PDAC starts small, goes many years, it's absolutely not accurate. Once PDAC develops, it very rapidly becomes a 2, 3, 4 centimeter PDAC, unfortunately. And those studies are now proving that. So yes, this is all very nice, innocuous, but once it infiltrates, it's the bad kind, so this is a very big problem. The diagnosis is also an issue. Gastric epithelial contaminants are indistinguishable from these gastric IPMNs. If I show this picture to pathologists, they would say, why are you showing me a gastric mucosa? This looks like just normal gastric mucosa. You know, all we need is put a couple of parietal cells and it will be a perfectly normal gastric mucosa. So it's indistinguishable from normal gastric mucosa. So we sometimes have to give the diagnosis, so that don't be upset about this. We have to just say, if truly from the cyst itself, then this may represent a branch duct type IPMN of gastric type. By the way, this becomes a bigger problem if the cystic lesion is in the tail, because the head lesions, usually the biopsy is taken from the duodenal perspective, but when you have the lesion in the tail, unfortunately, you have to go through the stomach. And by the way, no matter how endoscopists say, I really didn't apply pressure, you shouldn't have contamination. Unfortunately, real life is not like that. Going in and out, somehow some clusters can be obtained, and we see the gastric mucosa. There was a Japanese gastroenterologist who worked with me for about 2 years. He couldn't comprehend why there should be contamination if you're not applying pressure. And we have seen so many cases, and then he realized, yes, it does happen. So what I'm trying to say is, even if the gastroenterologists think they are not aspirating the normal gastric mucosa, it just comes to our specimen somehow. Coming to the more intestinal type IPMNs, they really look like colonic adenomas. They're often large, they're often complex, they're often main duct type, but the good news is when they infiltrate, it's often the colloid type cancer, MAC2 CDX2 positive, so actually it could be curable even when it's invasive. So that's a little bit different than the gastric entity. Then there's this rare but important new entity called intraductal tubular or tubular papillary neoplasm. Unlike IPMNs, these are more tubules that are non-mucinous. I don't want to go into the morphologic diagnostic criteria. They form more as nodules. They grow more as nodules in the ducts rather than more cystic, if you will. And that also has needs to be appreciated because its invasion is, although it's complex, it's usually curable. We mentioned mucinous cystic neoplasms. Technically, they are also adenocarcinoma sequence or tumoral intraepithelial neoplasms. Like I said, 15% of them have invasive carcinoma. By the way, that ovarian stroma really stains like ovarian stroma with progesterone receptors and all the other markers. They even have luteal cells. So it's really ovarian cortical differentiation. Now, this one may be important to keep in mind for you because this is called intraductal oncocytic papillary neoplasms. They form multilocular cystic lesions that are very complex, and typically radiologists call this cystadenocarcinoma, very understandably. Heterogeneous, complex, large cysts, and they're also inflamed at the periphery, so they look like they are infiltrating the vessels. But when you go in, actually you can shell it out and cure this patient. So it's important to recognize the features of this because 10-year survival approaches to 80–90% in these tumors. And they have a different molecular marker. I'm not going to go into the detail of that, but they have a specific molecular alteration. So intraductal neoplasms, the importance of this group is that they can progress into cancer, or they may have cancer at the time of diagnosis, but there are a whole group of other cystic lesions that form these multilocular cysts. They have their distinctive characteristics, like serous ones have glycogen-rich cytoplasm, acinar cystadenomas have acinar cell, squamoid cysts. The thing about this group is somehow most of them are benign, so there are very few cancers of these non-mucinous entities. So we are happy when we see a non-mucinous cystic lesion. So this is the generally algorithmic approach that I wanted to present. I don't know if there are any questions and comments, and I can move on to the more staging issues, R0, R1, and other things. Or we can take the questions at the end, maybe. Should I continue?
I think let's finish and then discuss.
Okay.
Take the questions.
Yeah. So this, we mentioned, I showed this picture earlier, PDAC, serous, ill-defined, subtle tumors, tubular configuration, desmoplastic stroma are the characteristics, and that they have extremely high ability to very insidiously, and insidious, I will use this term, insidious means very sneaky, very deceptive, individual small cells, very difficult to see microscopically and very difficult to see radiologically or intraoperatively. And that is a major problem because you see the main tumor here and far away from the main lesion, far, far away, a renegade duct, probably an intraparenchymal metastasis through a vascular channel. We won't call it metastasis, but spread. Far away from the main lesion. See, this is the biggest problem for PDAC. This is very common, as I will illustrate to you. Now, this brings me to the question of how big, for the surgeons in the audience, think about the Whipples you did. How big was the largest ordinary classic PDAC? Not colloids, not adenoscomas, none of those. But classical PDAC. How big was the largest one you really operated on? I'll bet you that actually it was no larger than 6 centimeters because a classical, in the Whipple, in the tail it can be. A classical PDAC can only be as large as the head of the pancreas. And head of the pancreas is about 6 centimeters. Why is that? It's not because it says, okay, I'm 6 centimeters now, let me slow down or I stop. The reason of that is because once it replaces the head, it has nowhere to go and goes to the soft tissues in a very insidious fashion. Again, now it's not a part of the tumor anymore. These are individual clusters. That's why we have intra-abdominal carcinomatosis, tiny little things that happen very commonly in these tumors. So when you look at the literature, mean size of PDACs resected is about 3.67 centimeters. Most are smaller than 5. And actually, one thing that helps us is if a head tumor is larger than 6 centimeters, it's probably not a PDAC. If, especially forming a compact lesion, you should start wondering about neuroendocrine centers and others. So expansile tumors, look at the serous adenoma, 22 centimeters. Of course, cells are together and growing as an expansile fashion, but when you have an insidious carcinoma, then it just replaces the head and then spills into the neighboring tissues. So this actually becomes a problem in determining the R0, R1 issue, but I will tackle this subject with what is R1, what is a margin in the pancreas, What are your views? So looking at this, can you identify the structures in this picture as surgeons? See, of course, as surgeons, you can recognize any small tissue fragment in situ. But when it comes out, I realize it's not as easy because the hallmarks are not there. You know, if they break down the building that you take a turn when you're going home, you may miss the exit. It's that kind of thing. The way we orient the specimen is what I tell the pathologist. First, we, of course, examine the externally, and then, in order to find the 3 margins, I tell the pathologist to put the long arm of the duodenum and stretch it. It will be somewhere here outside. And hold the pancreas in your hands and suspend it, which will give you this view. It's very easy for us. When you put it on the table, it just naturally becomes like this. And this is what I call the trapezoid. And the trapezoid corresponds to the vascular bed. And to the right of the trapezoid, to the right of the trapezoid is going to be the uncinate retroperitoneal margin. To the left of it is going to be the neck margin. So in this picture, this is another pancreas. This is our trapezoid. This is the neck margin. This is the uncinate retroperitoneal margin. And common bile duct is going to be at the top in the plateau here, invariably. So that allows pathologists to recognize these 3 important structures: neck margin, uncinate, and common bile duct. Now, in the literature, both surgery and pathology, everybody straightforward agrees that common bile duct, neck, uncinate margins are margins. And we sample them, we document them. GI resections, not so much important, but just documentatively, everybody samples it. Now, the question becomes, and here is where actually surgeons both input and it may be interesting to them, what about the rest of the pancreatic head? And that brings up the concept of margins versus surfaces. So this picture, again, neck and uncinate margin, but what do we do with this area? Is that a margin? So let's just take this picture. This is the vascular groove, vascular bed, neck, uncinate. This is the vascular bed. Now let's move. This is, by the way, I'm sure you now appreciate it. This view is the posterior median, right? You're looking for almost from the vertebra to the pancreas. Now let's turn and look at it from the right lateral side. What we have in our specimens is this area. It's clearly serosa covered, the transition from the duodenal surface to the pancreatic head. This is all pancreatic head here. This is the, I think this is the vena cava is facing this, right? So what do we do with this? Is this also a margin? Now we asked this question to surgeons. We did a survey by Pancreatibiliary Pathology Society, and I'm sorry, this was not like this. This must be the transition. I apologize for that. Europeans and Japanese wanted to call this, 80% of them said, yes, we would like to call this margin. Americans, they said no. More than half of them did not want to call this margin. And look, this is where I open a parenthesis. As pathologists, we can do whatever you guys tell us. I can call that a margin happily. I know where it is. I know what to do with it. What you need to tell me is, yes, call this margin, but not one of you saying something, other one saying something, then we don't know what to do. So the community needs to come together and decide whether we're going to call those margins. And clearly, they are not agreeing with each other. Now, here's where I take a stance. Posterior surface, if we're going to call this a margin, I think we have to call the anterior as margin as well. So we cannot be picky about that. You shouldn't put me in the position to deny myself, because if posterior is a margin, anterior is the same thing, that should be margin too. So this is the anterior surface. This is the duodenum, again, long arm. Anterior typically has, for pathologists in the audience, when you look at it, you can readily recognize because it's much more fatty, and the fat kind of overrides into the, do I have a picture of that? Overrides into the duodenum, just kind of goes on top of it. This is how we can recognize the anterior surface. This is the neck here. So this is this a margin or not? We asked this question as well. And surprisingly, a fair amount of Europeans also want to call it, but it may be the Europeans that we reached. You know, they may have that. By the way, maybe a gossip thing. So I realize actually the way to approach to these things are very cultural, in the sense that the paternal medicine, still paternal medicine in Europe compared to US. So in US, a lot of the things are shared with the patient. Patient is the decision maker, believe it or not. Those of you who did fellowships there probably know. Patient comes with the Google documentation and say, why are you going to give me chemotherapy? I don't want chemotherapy, I want this. You know, in Japan, it's the opposite. The surgeon says, go ahead and do this, this is it, this is what I'm giving to you. They don't even ask what they're taking. Seriously, I mean, I work with Japanese a lot too. Europeans are also more towards the Asian side, more paternal. So one thing about that is, you know, what you write in the papers could be different than what you practice. So in US, if we start calling margins, the patients are going to question, why are you operating on me if 80, 90% of these are margins? In Europe, Büchler will say, I have to operate on you. This is the right thing to do. Just come back tomorrow, I'll operate on you. And the patient goes and comes back the next day. In US, you tell them that, they say, no, 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 I'll go someone else then. Did they explain it well? I mean, that drives actually some of these figures, in my opinion. I mean, not my opinion. That's what they are also saying.
There is also another issue. Surgeons would accept anything as a margin when they have anything to do with it. If they cannot change anything, they don't want to accept it as a border.
Right. But again, Europeans are accepting it as a margin. That's because they don't tell the patient R0, R1. It's just for their publications. You know what I mean? Because the patient is going to follow what they say. In the US, you call it R1, the patient will come back and say, so you didn't do the right operation. You know? So that's the cultural difference that make a change in the approaches. So what do we do to address this? Again, these three margins are all agreed upon, no problem with this. The way we handle the uncinate margin is the following. Now, because of the way PDACs grow, often this is the area that they like to come to. This is the path of least resistance. There's a lot of adipose tissue there. So maybe I should phrase it this way. If there's a cancer going to this free serosal surface, often we appreciate that. There is fibrinous changes, there is granulation, and you palpate it and you know the tumor is coming there. But this area, this uncinate, is very fatty, and the cancer approaching to this area could be very patchy and hard to appreciate. So this we put entirely. So we take this uncinate area, we take it as a thick slice, 2-3 millimeter thick slice, and then we bread loaf, cut tangentially, and this is our uncinate margin. And it becomes a perpendicular margin. This is very important. I will explain this in more detail. It's a perpendicular margin, meaning cancer cells anywhere, we know there is cancer there. If the cancer cells approach to this black area I marked, which has black ink, that's when it's approaching the margin. The real margin is only this edge. Did I explain it well? Because this is a very problematic issue. We're working with the best-selling group, I don't know if they're online, about R0, R1 definitions, and this is where we actually have issues clearly in concepts. Perpendicular margin. So what do? We measure the distance from here. So we have a cancer here. In this slide, it's 1.25 millimeters. In this, 0.94 millimeters. We can measure it because only this edge and its distance with the tumor is what we will report. Here's an example again, PDAC. It's coming. Now, this illustrates another problem. So this ink here, there's a cleft here. Did this cleft happen while we were cutting it, while you guys were cutting it? Should we measure this from here? Believe me, it sounds like science, but we have problems with this. You know what I'm trying to say? I mean, these defects without ink. So, but we make a judgment call in these things, and if we are not sure, we call it close. So that's the perpendicular margin. It's how we take the uncinate. Most people are nowadays have begun to do it that way. For neck margin, this is another neck margin. Again, we have our trapezoid here, uncinate margin here. Posterior surface is not visible. We have the neck margin. The duct is usually for the pathologists in the audience, you can find the duct orifice in the upper outer quadrant. If you look at it from this perspective, upper right quadrant. And if you cannot identify the duct orifice, you can just take a cut and squeeze the pancreas a little bit. You see the juice coming back. But that you have only one chance to do the test, because if you have already manipulated the organ, that your chance is gone. So that's one way to find the duct orifice if you want to do that. But more important for surgeons is almost always we take this neck margin as shave en face. What do we mean by that? We take a very thin slice and we'll look at that face en face, and the whole face is margin. So when I have this slide as an en face margin, this is the main duct, the pancreas, fatty. So this is probably very fistula-prone pancreas. I know you guys get very jittery when you see this much fat in the neck margin. This is the surface, and anywhere in the slide, if I see cancer cells, it's going to be positive. So this is the difference between perpendicular and shave margin. Is this clear? This is important. Right. So if I see even one cancer cell right here, this is shave margin positive. So that there's another problem with this, because when we put it onto the cassette in a block, when our technician cuts this, they really need to cut as surface as possible, not go deep, because as they go deep, they're actually going towards the cancer. You know what I mean? Yeah. So that very surface they need to cut, and we look at it, and anywhere in this cancer is a margin positivity. Yes, sir.
Can I ask a quick question? During operation, while we transect pancreatic neck, we can send frozen section analysis in two different ways. We can cut a slice from the neck and send you while we are going on dissection. Or we can send the specimen after resection is complete. Is there any difference from pathological perspective, no, cutting that slice earlier for the sake of time?
No, there's no difference, provided that pathologists can identify, when you send the Whipple, they can identify the neck. One thing you may want to do, it depends on how your communication with your pathologist is. They may prefer not to look for it and you to send it. It makes it a little bit easier for pathologists. I personally would prefer to see the Whipple and take it myself. So you need to communicate with your pathologist to do that. But in reality, it shouldn't have any difference. Now, the biggest question, again, with Mark's group, Besseling's group, we're discussing this. Why don't we take perpendiculars from this guy too, right? Take the bread loaf and then lie it perpendicularly so that we can distance. Now, in frozen section, frozen is a horrible technique to begin with. Then having 6 blocks from every neck margin, because it will be multiple blocks. And interpretation of it is very difficult, so nobody is doing it. There's no pathology group who I know will agree to do it or is doing it. So unfortunately, that's our reality. Now, that becomes a problem because Marcus Büchler is pushing for 0.1 centimeter, right? Yeah, that's fine. I think for uncinate, we should be looking for 0.1. I really agree with that. But when you come to neck and common bile duct, we are putting it en face. There's no way we can give you distance. Is it, I don't know. This is a complicated thing. I don't know if I explained it well. Yeah. So, I mean, once you send us frozens from the neck, CBD, those margins are no longer evaluatable for distance. All we can tell you is there's margin at the very surface or not. Okay. And this slide actually emphasizes that. Frozen sections are obtained as shave en face, and then the margin distance cannot be documented. Oh, one thing about this, perhaps this slide. Again, this very main surface we look at, we don't see carcinoma cell. What happens is later on, next day, of course, the technician goes into it and makes a permanent cut, and there can be carcinoma cell in that very block, right? Because again, what we did is, you know, we have carcinoma going to the surface. We took the surface, we looked at it, we didn't see carcinoma cell. But as you cut even a few microns into it, you may bump into a cancer. Now, the way we report that is, you know, the main surface did not have cancer, so your margin was clear, but we are very close. Now, how close? Don't ask me that because it's gone. We cannot tell you how close anymore. Did this make sense? I actually, in my conversations with the Amsterdam group, they're fantastic, by the way. I love those guys. They're so good and so organized. But the conversation with them made me realize actually this shave on phase and perpendicular is not well appreciated in the surgery field. Frozen sections, this is actually reflecting our reality about frozen section versus a conventional section. Look at this, we can tell islets. Most of you who looked at some pictures, I'm sure can tell this is an islet of Langerhans. These are acinar cells, these are ducts, beautiful. That's what a pancreas looks like. That's what a frozen section of the pancreas looks like. All blue, purple. I don't know which one is a duct. I don't know which one is an acinus. I have no clue which one is an islet. It's all crushed, frozen, burned, and of course you do a little bit cautery there, it gets even worse. So yes, unfortunately false positives and false negatives is one of the highest in entire body in frozen sections in the pancreas.
Can I ask you a question?
Yes.
So should we emphasize on the technique that we use during the transection of the pancreas? If someone uses electrocautery during the transection and sends you a slice for frozen section analysis, does it make a difference?
It does. I mean, for neck margin, by the way, you shouldn't be even frozen. I'll show you why I say that. I'm happy to do it. I love looking at pancreas. I'm not complaining about it, but reality is you shouldn't be doing frozen sections, and why will come out in a few minutes. But for other organs, for liver, for instance, cautery, and there you need that frozen section. And cautery changes makes it sometimes impossible to tell what is what. So the less you thermocoagulate during the operation, if you're focusing, let's say there's a certain area that you really want to know whether it's margin positive or not, try to avoid, at least in that area, burning it too much, because a frozen section is going to cook it, we call it cook it, make it terrible anyways. If you add to it by thermocoagulating, it becomes very mistake prone. Yeah, frozen section is like looking at these, CTs from in a bad machine 20 years ago versus a very good MRI. It really destroys the tissue, quality is low, chances for more organized diagnosis is lost, like for the distance and all those things. So this brings me to this, again, Besseling group organized analysis. They did a phenomenal job in organizing, and this is actually their early summary that I'm quoting. By the way, this is confidential because it's going to become a paper, but some of this thing I already knew and contributed to anyways. I was a co-author in these two papers. Now, this shows for frozen section purposes two things. I know the numbers are small, and I hope you can see some of them, but there are 2 points here. One is false negative rate of frozen section is about 2 to 5%. Okay? Yeah, there's 0.9 in some studies, but in reality, it's about 3–4% in any institution you go to. Now, one thing important to appreciate, this includes all Whipples, and every margin is frozen. Actually, when you're dealing, if you take the cases that were really close to the neck anyways, and evaluate that data, probably this 2 to 5% is going to be even higher, because again, pancreas adenocarcinoma is very subtle, very difficult to diagnose. So yes, false positivity rate, unfortunately, and false negativity rate are quite high for our taste. Now, this part here, I'll just summarize to you. When frozen section is positive, additional surgery achieved R0 in 2/3 of the cases, still leaving 1/3 as R1. So because you expand your surgery, you think there is no tumor there, but actually microscopically we find tumor. So yes, 60%, but leaving about 30% even with additional surgery. But now the most important thing, and again, our study also was one of them, most of the studies doing the additional surgery achieving R0. So you did the frozen section and it was R1, that was positivity. You said, okay, I'm going to extend the surgery. You did it, and you converted it to R0, you would think survival improved. Actually, it's the opposite. Survival still doesn't improve, and in some cases it was worse because probably operation extended, maybe the fistula chance extended. I don't know what it is. They are investigating it. But one thing for sure is a fact that conversion from R1 to R0 by frozen section and additional sections does not help the patient, actually maybe making things worse. So the conclusion of this, I think eventually, where this is being discussed, is neck margin frozen sections are not justified. Again, I'm not saying this because, by the way, I love doing frozens. I love looking at frozens. It gives me material to present in courses. thankfully, very few, if any, mistakes. But this is extremely difficult for pathologists. So really, I have to be defending the pathology field and emphasizing the challenges. And this brings us to the R0, R1, R0 rate. Look at this, please. So this group was fantastic, huh? 17%. This group is terrible, 85% margin positivity, right? What are the factors that lead to R0, R1 rate? So at the same time, look at this. These are papers from surgery team. I just selected, by the way. There are many others, very similar results. 3 major studies. Their rates are 17 to 40, 45%. These are all pathologists. The rate is 75 to 85%. Okay? Why is that? Because, of course, the criteria used, 1 millimeter criterion. If you use 1 millimeter criterion, suddenly everything is much higher. If you use surfaces as margins, both anterior and posterior, like this Verbeke study, both anterior and posterior was used as positive. Sure, there are going to be a lot more cases positive. And then also sampling. I cannot overemphasize this. You know, the more sections you take, the more things you'll find. And especially PDAC, which is very subtle, going everywhere. If you take one section, you may hit the negative area and say, perfect, R0. If you take a different angle section, so the more sections, of course, you'll have higher R1 rates. And we need to kind of standardize this, but it's not easy. What's our approach? First of all, we try to provide the parameters for every aspect, margins, every surface separately, such that, like, for instance, we report vascular bed, we take it separately, and just a vascular bed involved by carcinoma on its surface. So 5 years down the line, one of our residents want to do a study, they can go back, and we decide that that's actually a margin, they can go back and include that in R1. We document everything for at least academic purposes. For the uncinate, like I said, that's the margin, in my opinion, the most important. We bread loaf and give the distance because it's a perpendicular margin. We call it tumor is at the margin, or margin is negative, but it is within so and so millimeters for that particular margin. Again, I cannot do that. Nobody can do that unless they are doing perpendicular for those as well. For the neck and CBD margins, because those are obtained en face, all of it is just positive, negative, period. Now we come to the surfaces. Here's how we deal with the surfaces. It's not what everybody does. I think I like it a lot because it's very informative. We call it the orange peeling. We essentially peel the surfaces of the pancreas to obtain the lymph nodes. I'm going to show you what I mean by that. This is the posterior surface again. In the next picture, you'll see this part orange peeled out, meaning the fat will be dissected. We just, you know, very crudely take out the fat there with scissors, sometimes with a knife. And in this one, we did also posterior surface. This is posterior pancreatodudinal. And we end up putting these into 8 groups. Not an official grouping, but it's actually good for research purposes. And we take the lymph nodes from these. The purpose of this, by the way, is to find all the lymph nodes. Do we have time for a story? So the way, yeah. So the way, of course, the fields grow is quite fascinating. So there was a Tomlinson article some 15 years ago. It came out as a surgery article that says the separation curves of PDAC for survival lymph nodes is 15. If it is 15, 0 of 15, much better prognosis than positive of 15. But for lesser lymph nodes, you don't get that kind of survival curve difference. Okay? So then I start to get phone calls from all the pathologists. They looked at their data and they're now finding 15 lymph nodes, right? So it's like they're asking me to find 15 lymph nodes because surgeons immediately picked up those and went to their pathologist and said, I want 15 lymph nodes in every pancreas. Okay? So, and they looked at their data and they're finding 7, 8, they're never 15. So the fascinating thing is I should have put that article. When you read that article, actually they say they're analyzing the SEER database. By the way, SEER database is a terrible database. The lymph node average was 7. It's just that when there was 15, 0, 15, they found the survival curve. They weren't saying you have to find 15 in every case. But of course, now the surgeons say, 15 is the number. Why can't you find 15 lymph nodes in my pancreas? But the reality is then we start to look more carefully. I did this orange peeling study, and indeed, the numbers went up significantly. That's why we evaluated 12 to be the bottom number. So our protocol is if we identify less than 12 lymph nodes, we go back to the specimen and take a lot more sections to find more lymph nodes. That's our protocol. Now, actually, we don't have issues. We really look carefully and find more than 20 in most of our cases. Yeah, so and we published this orange peeling. The orange peeling helps us to find the lymph nodes before we even chop the specimen. We take out these soft tissues where the lymph nodes are normally so that we can deal with them later. Then we cut the specimen. Because once you look for the lymph nodes after cutting the pancreatic head in the growth room, it becomes harder to find the lymph nodes. That's why probably these numbers were very low. Another thing this soft tissue helped us understand, which was a little bit of a surprise, is when we looked at them, and this is random section you have to understand. So we take these soft tissues in 6 different areas, and we look at it microscopically. Let's see what is there in addition to the lymph node. And we found renegade PDAC foci, little, far away from the main tumor in 89% of these. That's why, that's why I'm trying to say with PDAC is so disseminated by the time of diagnosis. And actually, the remaining 11% did not have. One thing I said, did I show that picture? I think coming up, maybe. Yeah. So one thing the field needs to decide, surgeons from different continents need to come together and tell us which one is a margin, posterior or anterior. Are they also to be included in the margin? My approach, we call this surfaces for now, coming from the rectum perspective, right? When there is a radial margin involvement, radiotherapy, when it is the free serosal surface, it's believed that the access is to the abdominal cavity, so chemotherapy is indicated, right? I mean, the margin is something, I did 2 years of ENT residency, so I come to these things from surgeon's perspective in some ways. So, I mean, if this is not something you cut personally as a surgeon, we shouldn't be calling it margin, is my opinion. That's why free surfaces, I report as free surfaces. But you all come together and tell me from now on you report it as margin, we'll do that. We identify it and we section it. Another question is how many sections? It's important to note that some of the studies from German groups, they do total sampling. Well, nobody can afford that. In the US, nobody's going to do that. It's too expensive. But that's what they're doing. Again, paternal, government pays for it. We could probably do it. Not we as Koc, but in Turkey, state hospitals can do it. But it's too expensive. And then, of course, 1 millimeter criterion. Now, one thing as a pathologist, I also would like to emphasize to you all is when I moved from surgery, from ENT to pathology, I realized I didn't appreciate this at all, that I thought they were looking at everything. Pathology was examining everything. I don't know why I didn't think. But in reality, if you want to examine every corner of this Whipple specimen, you have to spend $100,000 because you need to take 5 micron suctions, which translates to 6,000 slides, and 12 technicians working only on that specimen for a full day, et cetera, et cetera. What I'm trying to tell you is there's no way anybody can look at every corner of this. With pathology is art of sampling. We do targeted sampling. That's why uncinate is very important. We examine this a lot more carefully than other parts. Oh, by the way, if anybody gets grant and want me to do this, I'll be happy to look at 5,400 slides of pancreases. It's a lot of expense. I cannot do it here because I cannot lock my technicians for that. But I'm actually very curious to do these things with 3-dimensional and stuff. It will be interesting. The neoadjuvant challenge is the last. Do I have a few more minutes?
We are running out of time. Just
very quickly, just one quick message. There's a lot of hype about the neoadjuvant grading and classification. Of course, it doesn't work that well except for if there is no carcinoma, right? I find the MD Anderson, Ho-Min Wang's approach the easiest and the best. No residual carcinoma, we all can agree. They call it less than 5 residual carcinoma, less than 5%. Now, this 5%, these percentages, and every one of these use that. I don't know how you can calculate the percentage. I wasn't there when the primary was there. You gave neoadjuvant therapy. I don't know what 100% was. How can I give you a percent of the denominator I have not seen? So actually what we are saying is we are estimating very minimal tumor versus a lot more tumor. 5% is a funny number, but what I use this as, you know, many slides, I look at it and I'm having a hard time finding the cancer cells, that's for me grade 1. And if I see cancer cells very commonly and comfortably, it's either grade 2 or grade 3. So this is important for the message for the pathologist. Our protocol in order to call something no residual disease after neoadjuvant is quite harsh. First of all, this is extremely uncommon. I've seen, I think, either 3 or 4 cases over the years, extremely uncommon. Our approach, obtain and examine the diagnostic biopsy, it probably was a pseudotumoral pancreatitis or something else. And then we submit the entire pancreas, and then we select a few blocks to take more sections, and actually we melt the block, turn it upside down, and look at it again just to make sure there is no cancer in it. And that's, I think, and the measuring of these tumors are also tricky, and that's, I think, all I prepared to tell you. Thank you very much for your patience and attention.
Thank you.